Okay, so when we talk about documentation, all nursing documentation is legal documents that have to do with an assessment of the patient that includes always subjective information, and these are things the patient tells you, and objective information, and these are things that you can assess objectively, right? And so when we talk about different formats like a narrative notes are typically used for admissions because a narrative will give you a story. It paints a picture. You know, just admitted this 79-year-old Caucasian female, because of chest pain. Patient complains of angina, vital signs, boom, 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 et cetera, et cetera. So a narrative note is like a story. When we talk about those different formats, they really are protocol based on facility. So in other words, it's not like one is always used in a certain setting. The one that always comes to mind that I like to talk about first, charting by exception. Charting by exception means that if there's nothing that you've assessed that's outside what's considered to be within normal limits or within a normal range, then you just write nothing. Charting by exception is a problem because if you don't have to write anything, nurses typically don't write anything. And then down the line, if there's ever any kind of a problem with the patient and that documentation gets pulled, then attorneys look at it and they rip it up. I've watched them make nurses cry on the stand. Well, you didn't write anything, so you didn't see the patient. How many hours went by before you even checked on the patient? You see the problem?
Mhm.
And so the protocol is dependent on the facility, whether you use a SOAP note, a narrative note, charting by exception, right? But all notes share commonalities. So there's always going to be somewhere to document the patient's status. In other words, their vital signs. And basic vital signs always have to include heart rate and rhythm. Rate and rhythm, heart rate, 82 and regular, or 102 and irregularly irregular. They have to include respiratory rate and quality. So respiration, 16 and unlabored. Clear to auscultation, all fields. Blood pressure, that's easy, something over something, right? Or if you do orthostatic blood pressure, which means when the patient changes position. So you would say, blood pressure sitting is this over this. Blood pressure standing, this over this, right? And it always includes temperature. And then you have to document what the temperature is and where it was obtained. Was it axillary? Was it temporal? Was it oral? And it includes the pulse ox. So the pulse ox, and you indicate whether that pulse ox was obtained at rest, on room air, with activity, on oxygen, and if it's on oxygen, how much and how are they getting it? In other words, pulse ox, 97% on 2 liters of O2 via nasal cannula. Right. And then the last part of it for the vital signs is pain. Did the patient complain of pain? And if the patient's awake, alert, and oriented, you always document using the pain scale. And pain is whatever your patient tells you it is. So in other words, if you ask me, hey, what is your level of pain? 0 is no pain, 10 is the worst pain you ever had. And I'm laughing and I go, my pain's a 7, you have to believe me, because everyone handles pain differently, right? Doesn't mean that a 7 patient's gonna be screaming and yelling and hollering. And if you document pain, then later on somewhere in that note, you have to document what you did about it. So understand, whenever you document something that's a problem, that's outside what's expected, outside normal limits, you must document the intervention within that note, regardless of the format of the note. So if I tell you my pain is a 7 out of 10, you would say, patient states pain 7/10, and that's understood universally. That's the pain scale. Then you have to tell me, what did you do? Did I have an order already, for Percocet? Administered Percocet 5/325, right? Or call doctor to get orders, right? You have to document what you did. So the format really depends on the facility. It's like dealer's choice, What do you guys want to use? When we talk about the documentation itself, like I said, the commonalities are always subjective information. So you got your vital signs, pain included, pulse ox included. Why is the patient here, right? So if we're talking about a hospital, chief complaint, you know, if it's an ER, stomach pain, patient states, and you say patient states, comma, quotation marks, and write down what the patient said. My stomach hurts. You know, you write that down. And then your assessment, which is the objective information. So what are you assessing in the patient? So now when you talk about a focused assessment versus a head to toe or comprehensive assessment, you always do a comprehensive assessment on every patient. However, if the patient has a chief complaint that's of an urgent nature, that's going to be your focused assessment first. I'll give you an example. If you work in an urgent care setting and the patient comes in and they're having chest pain, you are going to do cardiovascular focused assessment first, because when somebody complains of chest pain, are they having a heart attack? Well, you don't know. And so you have to do that focused assessment and document that focused assessment first. So you're going to ask a lot of questions about where's the pain? What makes it worse? What makes it better? When did it start? So what, precipitating events? Did you fall down and then all of a sudden your chest hurt? Were you mowing the lawn and then all of a sudden you started getting chest pain? See why that's important? Because that has a bearing on, it directs you on what questions to ask next. To decide, is this angina cardiac or is it maybe musculoskeletal pain? So, and then your focused assessment for cardiovascular would continue and include maybe an EKG, getting an EKG on the patient and listening a little more closely to the heart rate and rhythm. Checking for cyanosis. Does the patient look blue, which would indicate hypoxia? Patient's not getting enough oxygen. Does the patient appear short of breath? Dyspneic. Are they using accessory muscles? When people breathe, they shouldn't be doing this. Those are accessory muscles, shoulders, sternocleidomastoid muscle, making their whole body move to help them breathe. That's labored breathing. So cardiovascular focused assessment or whatever based on the chief complaint. And then you would continue and do your head to toe or comprehensive assessment, right?
Go outside. Go pee-pee. Go. Sorry.
That's all right. So what I can do is I can share a note with you while we're talking and kind of give you some ideas of the different types of notes and what they look like. So with some patients that I kind of made up. All right. So any questions so far?
No. Well, actually, yeah, but not about this really, because you mentioned a focused assessment, and that's going to be, so we have our practicum at the end.
Right.
And so we can start it now. So we have there's like 3 skills: the blood pressure, brachial pulse, and radial pulse.
Okay.
The two-step blood pressure. And so we have to record ourselves doing each of those.
Yeah.
That's part of our practicum. And those I can do. I'm going to record those ahead of time so that way I can just turn them in at the end.
Right.
When it's time.
Right.
But the last part of our practicum is going to be a randomly chosen focused assessment, but I want to record all 4 of them ahead of time so that way when they choose one for me, I can have it ready and just submit it.
That's a very smart idea.
So I guess I don't really know what a focus, I guess we haven't gotten there yet.
You're going to see. I'm going to show you.
We haven't gotten that far yet, so I'm trying not to get ahead of myself because.
Right. Okay, so I'm sharing my screen with you. So this is an example of a narrative note, and I'll send this to you so you can see it, right? And this is narrative note for an admission. And you'll see what I mean with an admission. You want to tell me a story. Who is the patient? Tell me about them, their history, that kind of stuff. Why are they here, right? So when you look at this note, you see, here's the date, the time. 86-year-old male admitted on this date for a left CVA. So he had a stroke. Okay. Vital signs, I give temperature, heart rate, and then when you see RRR after the number, that means regular rate and rhythm. Respirations 20,
There's nothing
blood
missing.
pressure.
Just they fell over.
No.
Blood pressure 140/76.
Sorry, Mom.
It's all right. 96%.
That's high, isn't it? Isn't that high?
What? Is what
Is
high?
that considered high?
What?
His blood pressure?
No.
His blood pressure?
Yeah. No, honey.
Excuse me.
I mean, it's a little on the high end of normal, but he just had a stroke. He's lucky that that's actually great for him. And you'll get this as we move along, so easy. His pulse ox, 96% SpO2 on RA, room air, at rest. Pain, 6 out of 10 in the right lower extremity and right upper extremity as stated by patient, right? And then I go on and talk about alert and oriented ×3. And head to toe, you start at the head and you work your way down. So we talk about vital signs, and then we talk about, is he awake, alert, and oriented? Is he confused, right? What's going on neurologically? So he responds appropriately to verbal stimuli. Pupils are equal and reactive to light and accommodation, and I'll explain that. 2 to 3 millimeters bilaterally. Mild dysarthria noted, which means he's having a little trouble talking, right? He's got expressive aphasia, and we're utilizing a word board to facilitate communication. We have orders for PT and OT, eval and treat, and they're received and noted. Then we look in his mouth. Oral mucous membranes are pink and moist. His tongue, midline, uvula, slight deviation to the left. And the uvula, that little punching bag in the back of the throat. And you see what I mean? So we are literally going from his head down to his toe, right? And looking at everything. What does his mouth look like? What about his teeth? Can he swallow? And that's important because of the stroke. And so in this note, an admission note, we've kind of put all the things together. Focused assessment based on neuro, because he had a stroke. And then we've also incorporated our head to toe assessment within it.
I'm gonna get that stuff. I was just having them play with that in here. You didn't have to clean that up.
You want me to pause
Sorry.
for a minute?
No, it's fine. I'm gonna sit down. I just wanted to let the dogs out because they just woke up. But
Okay.
they're back. I'm good. Go ahead.
So anyway, and so we go down the line. You know, when we talk about his mouth and his swallowing problems, we talk about his diet. And then we talk about his status as far as his throat and neck. IVs, grips, hand grips, so hand strength, lower extremity strength. Anyway, so I'll send you this note. So this is a really good example of a head to toe with a focused assessment in it. Okay, so what is the difference? Like I said, a focused assessment is you're assessing a body system based on the chief complaint. Why is the patient here? What's their problem? Right? If somebody's in because they have a rash, you're not going to be worried about, you know, their speech, right? If somebody's in for my leg, I fell off a ladder, you're going to be focused on that extremity first. Then you're going to go in and do the head to toe. So a focused assessment is just part of the head to toe that's very specific to whatever the complaint the patient has is. That's all it is.
I'm sorry, Mom. Hang on a sec.
Were you talking about my blood pressure?
No, she's showing me. She's explaining something to me. I was having trouble understanding something, so that's why. Okay. He thought I was talking about his blood pressure. Go ahead.
What's wrong with his blood pressure?
Nothing. When I took it, it was 120/80. It was like perfect. I can't hear you now.
80's too high. That's not perfect.
Well, that's what we have listed as normal.
Not normal. The American Heart Association changed that 10 years ago to 120/70. Tell your school to catch up.
120/70. Well, I guess I should, but it's in the book and it's in like everything. So
What book are you using?
Oh, I don't know how to minimize this to pull it up.
Don't worry about it. Don't
It's-
worry. You can tell me later, but I'm telling you 120 over 70. It was changed 10 years ago, so the book may be outdated. I don't know. You live in Carolina, so it's very probable. Anyway,
What was the damn book
but you have
called?
to listen. The book, oh, I always tell people, your book is your guide. So if your textbook is telling you repeatedly that that's the norm, then you have to go with that. So if
Yeah.
I tell you something like that's really not the norm, don't worry about that. Forget it. Just go with the book.
Okay.
Okay? Because they're going to, if they test you, they're testing you on the information they're giving
Yeah.
you. Right. The Board of Nursing won't. So I'll help you with the boards when it gets time. All right. So anyway, so when we talk about that comprehensive assessment, that's a head to toe assessment. You're checking everything. Focused assessment, what is chief complaint? Okay. And then you mentioned SBAR. So the SBAR is a document that literally was invented by a team of nurses and physicians that were put together by the Department of Health and Human Services, which is who runs Medicare and Medicaid for the United States of America.
Mhm.
About 15 years ago is when they started working on that, because a nurse will call a doctor and she'll say, "Doctor, Mrs. Jones's heart rate is 128. Yeah. And like, what do you want? So if you're calling a doctor, obviously you need something, but you can't tell the doctor one thing, like, what do you want from me and what's wrong? I don't understand why you're calling me. And so you don't want to have to play 20 questions with the nurse to say, all right, so it's 128. Is it irregular or regular? Is she diagnosed with any cardiac dysrhythmias? Is she medicated for cardiac dysrhythmias? Is she symptomatic? Is she dizzy? Is she weak? Like, I need more information. So that's why they came up with the SBAR. And the SBAR, and I'm going to pull one of those up for you too, means situation, what's going on, background, tell me a little bit about the patient. Like, I need to know, is she allergic to anything? Because if she is, that's going to direct me to not order something that she's allergic to. You know what I mean? So it's a one document that puts all the information that you need to have an intelligent, succinct conversation with a physician and not sound like that. So the SBAR is really, I mean, it's one of the best things that they ever came up with, but here's the problem. People don't use it. Things only work if I give you a tool, you have to use it, right? Just like, you know, my students, I have cheat sheets, Cass, for everything. Everything. And sometimes they don't touch them. And I'm like, why? When I'm telling you, I'm giving you a gift. Why would you not use it? Silly, you know? We get you the SBAR. And it was part of something Medicare called the Interact Toolkit. And it's about interacting between nurses and doctors. You know, so it's loading. Hold on. Here it comes. There you go. Can you see the screen? Can you see the SBAR? Or must I do a new share?
It's still the, oh, yeah, okay.
Hold on. Do a new share. And there it is. Okay, let me make it a little, can you see it?
Mm-hmm.
Okay. And so before you call the doctor, you have to evaluate the resident or the patient, right? You have to vital signs, all of them, not just the heart rate, like what's her blood pressure, that's important too, right? And you have to look at the patient's chart so that you know like what's been going on with the patient, right? You have to review the relevant care path, and we'll talk about that. And then relevant information like their allergies, advanced directives, are they a DNR, DNI, DNH, do not hospitalize, do not intubate, right? So when we go down and we look at the document, we see situation, the symptom, the sign, the change, whatever I'm calling about is blah, blah, blah. So let's just say you're working in subacute, which is a nursing home rehab, right? And you have a 72-year-old female that's in for IV antibiotics. You go in the morning and she's got a change in mental status. So she was alert and oriented yesterday. This morning you go in, you're like, good morning, Mrs. Jones. How are you today? Today. That's echolalia. And you're like, uh-oh, something's not right, right? So why are you calling the doctor? When did it start? Did it get worse or better or stayed the same since it started? What makes it worse? What makes it better? And anything else that happened different with that thing that you're calling about. Right? So did she start a new medication yesterday and now today she's all fucked up? AFU? You see? So that I could put two and two together and go, I wonder if it's a medication reaction. Or did nothing change and she literally woke up? Okay. So then next part is the background. And the background is basically just like it says. Tell me about the patient and like what's going on with the patient. Why are they here? What's their primary diagnosis? What's their history? Recent history. Don't tell me she had a tonsillectomy when she was 12. And she's 72. I don't give a shit. I'm surprised. Her vital signs, her pulse ox, and they even guide you here, right? What percentage on room air or, 102? How much? How is she getting the oxygen? Have there been any recent changes in her function or mobility? Any new meds? Any new mental status changes? GI or GU changes? Pain changes? Her appetite decreased? Or is she not drinking suddenly? Did her wound get worse or does she have a new wound? Did you get labs back and you're worried? And what are her advanced directives, allergies, and anything else that might be relevant? And then assessment. What do you think's going on? What do you want from me? If you're calling the doctor, you have a clue in your mind, hopefully, if you have two brain cells, about what's happening. And so you're calling because you want something from me that you can't do. You can't write an order for labs independently, so you're calling me because you want to check something. She started digoxin, and all of a sudden she's complaining of blurred vision. You're like, oh, I think she's dig toxic. Can I get a dig level? Right. So what do you think is going on? Or is it really like with LPNs? Don't worry about that. I don't even teach that to the LPNs because they're not necessarily able to go, I think she's got a 2nd-degree heart block. She's just different. I'll take it from there. Right? So, and then what do you want? It's the R. What's your request? What do you want? Do you want me to see the patient? Do you want labs? Do you want an x-ray? Do you want an EKG? Do you want me to start IV? What do you want from me? What order do you want from me? You want to send her out to the hospital? Or if you're in a hospital, what do you want to transfer her to ICU because there's been a sudden change? What do you want? So this form makes it easy to communicate with the doctor or the nurse practitioner. So any questions about any of this so far?
No, but I was wondering if can I share my screen with you and show you the assignment for this?
Yes, of course. Hold on. I will let you share your screen. Stop share. And do. La 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 la
Cash, your
la.
mom does this in her sleep.
I really do. It sucks. It sucks.
I know, I feel bad making you give another lecture when you don't have class.
No, it's like nothing.
It's
for her. That's not.
Yeah, no, it's like this is so, at this point, I could almost just go, all right, turn it on, click, start talking, and still be watching TV while I'm talking to you because, allow. No, I don't want that. Hold on a second, let me pause. Okay, you can share. Just, how to hover down the bottom, share screen. Just float your cursor down the bottom and you'll see share screen, and then a window will open up. It'll say basic or advanced. Advanced is better. Up at the top, you see basic and advanced. Click on advanced and then click on the one that says portion of the screen.
Okay. And then share.
And then share. And now open up that document. Because I know you have it digital.
Okay.
Okay.
It's showing you. I see. This is the screen. I see. I can make it bigger or smaller.
See how quick you got that? Do you know how long that takes me to fucking explain? Do you have any idea? That's a 20-minute conversation.
Or
Yeah, sometimes longer. Do you see where it says share? I don't see it. Hover the mouse. What does that mean? Oh, God. Anyway, I'm just venting now. Sorry.
Okay, hold on.
Yep, and then just open it. There you go. Now make it bigger, and you can move. See where our faces are in the little box?
Oh, yeah,
Hover over it, and you
and
can
move it. Yeah.
click it and move it out of the way, and then make your portion of the screen bigger so I can see the whole document.
Okay, so review the following SBAR
I don't need
report
you
on
to read it
patient.
to me. I can read it. Hang on. 907 narrative note, 800 and 1200. Okay, assessment was part and data assessment. Okay. All right, scroll down. So, or in taking care of Mrs. Anderson, and we're going to change the baseline assessment 12. Make sure you're aware. That's a shitty ass note. Post-operative patient. Post-operative for what? Who wrote this? Haley? Here we go again, shitty instructors. I need to get a job at a university, man. These fucking people suck. She's telling you she's a post-op patient. What did she have done? You know what I mean? I have no idea what to even.
Maybe that's why they're asking data, list other assessment data not listed in the SBAR
Right.
that
So
a
they
nurse
need
would
you
need to collect.
Oh, okay. There you go. So
So that's probably why.
right. Okay. So we'll start at the beginning. So like, let's see if you recognize some of these things. So here, situation. Hi, I'm the RN taking care of Ms. Anderson. I've noted changes in her vital signs and baseline assessment during 1200 rounds. I wanted to call and make you aware of what was going on. So what's your name? Do you have a name? First of all,
Yeah.
right? And and then again, when we talk about the situation, what do you mean changes in vital signs? Like a little more specificity. This is the other problem too. When nurses talk, sometimes they are vague. If you're calling, just imagine I'm calling you, so you can't see me or the patient, right? So you're my eyes and my ears. With this information, what do you want me to do? So you're telling me at 800, her vital signs were 98.6, radial pulse, 80 beats per minute. Was it regular? Was it irregular? Why didn't you do an apical? Blood pressure 120 over 80, respiratory rate 12, oxygen saturation 100%. 100% on room air. How old is she? What is she allergic to? What's her, I mean, you're not giving me any background at all here.
I guess that's the point, right?
Yeah,
For us to
so they
figure out.
made, now I get it. Yeah, they made this a really shitty note purposefully. And if you're telling me she's post-op, I need all that information. What did she have done? What does the site look like? I need an entire focused assessment just on the post-op issue, you know? So for example, if you're telling me she's post-op and she had her gallbladder removed, so that's a cholecystectomy. Well, was it a laparoscopic chole or was it an open chole? In other words, did they cut her open and she's got an incision, or does she have 4 puncture wounds in the abdomen? And what does it look like? You know? So all those things are important to know, because here, what you're telling me is very little. So her breath sounds are clear. She's ANO times 3. Very little pain at 8 a.m., right? 2 out of 10. Let's see, skin and nail color pink. S1, S2, heard in all 4 valve areas without abnormal sounds. Apical pulse 78 beats a minute, regular rhythm during 12 o'clock, lethargic, she can't breathe, pain with inhalation, breathing shallow and rapid, pale color, crackles in her lungs, temperature went down, 120 beats a minute, blood pressure's dropped, respiratory rates increased. Okay. 2 things.
Would we need to know if she's taken any medication, what medication she's taken, or no?
Well, you do need to know medication, allergies. her age, there's a whole shit ton. But here's what I'm about to say to you. And this is the problem that I have too with nursing school. So they're telling you that now at noon, so at 8 a.m., she was apparently fine. And then the nurse goes back in at noon, and now she's lethargic, but she's having difficulty breathing. If you can't breathe, you're not lethargic, you're anxious. Okay? Breathing pattern, look at me, shallow and rapid. Here's what that looks like. Would that be lethargic? And why does she have crackles? If you're telling me, so crackles in lungs is fluid, usually relevant to heart failure,
Yes.
pulmonary edema, okay?
Yes,
All
Eli,
the other
still
signs
alive?
point to a pulmonary embolism. Why does she have crackles? It's not consistent with the vital signs or anything that they're giving you. Respiratory rate of 26, increased pain, blood pressure dropped, heart rate increased. So she's either got a hemorrhage, an internal hemorrhage, or a pulmonary embolism, but I don't understand why she's got fluid in her lungs. Because fluid in the lungs, pulmonary edema, her blood pressure would be elevated. It wouldn't have dropped. So this is still, I go back to my original statement, shitty nurse wrote this. But anyway, so there's a whole lot of information missing, right? Recommendations, begin to critically think about what's going on with the patient, what your recommendations would be. It's to help you think critically. I'll give you a whole lot of recommendations. Rewrite it and fix it. Because if you're telling me she's got a pulmonary embolism, which is a common sequelae to operative patients. So, do you know what any of this is? Probably not. A pulmonary embolism is a blood clot that happens in post-op patients secondary to immobility or secondary to other factors, like if she had orthopedic surgery, like a hip or a knee, then she could have a fat embolism, which is very common. And what happens is a little piece of fat or a little blood clot develops and travels. And in this case, travels to the lung and blocks the blood flow from the lung to the heart. And what you see in the patient is a sudden change in status with heart rate crazy high, respiratory rate crazy high, cyanosis, decreased pulse ox. Like she doesn't give you a pulse ox at 1200. Right? There's a whole lot of information that's missing from this, a lot. Right? So if it's a pulmonary embolism, what do you want? You're going to get her on oxygen immediately, get the head of the bed elevated, and you want a BQ scan right now, immediately, right? And you want her on bed rest. So that's a ventilation perfusion scan to look for a pulmonary embolism. So, but let's go back to the beginning, all right? So when you call the doctor, you always have to tell them your name. You have to tell them, Mrs. Anderson, who is she? How old is she? Where are you? What facility are you even in? You don't tell me. I don't know. Are you in a hospital? Are you a nursing home? You know? And why is Mrs. Anderson there? You need to tell me a story with that situation. So she's missing a ton of information. And then with the background, post-op what? So she's post-op from yesterday, then I'm going to assume that you're in a hospital. And I'm going to assume that she's not in PACU anymore, that she's on a regular floor, like a med-surg floor. So when a patient goes into a hospital and has surgery, most of the time, after surgery, they go into PACU. PACU is the post-anesthesia care unit. We used to call them shake them and wake them, lazy ass nurses. All day long, that's all you do. You wake patients up. That's what PACU is. They make sure that you come out of anesthesia, awake, alert, and oriented, and that your gag reflex is intact, and that you're stable enough to go to a regular floor to recover, right? And so that's typically what happens with most post-op patients. But if she had a minor procedure, and again, we don't know what she had done, minor procedure like a knee arthroplasty, right, which is a minor procedure in a surgery center, She could have gone yesterday from a nursing home to a surgery center, had that knee done, and come back to the surgery center. So, or come back to the nursing home.
Nursing home.
Yeah. So the point is like, I don't know really anything at all. So what you want to do is you want to look at that SBAR, which I'll send you, and you want to just look at all the information, because imagine if you're the doctor, right? You're the doctor, and this is the call that you get. Don't you have a ton of questions that you want to ask to try to figure out what's going on? Being a nurse is like being a detective, right? You have a lot of questions that you have to ask, and you have to try to figure out what's going on. And the doctor is the same thing, but just one level above you, right? And so how can the doctor give you orders or do anything for you if the doctor doesn't have the whole picture? So this is easy. I mean, I would butcher this in about 10 minutes.
I guess, well, also because it says that she hasn't ambulated in the hallway or used her incentive spirometer. Isn't that important?
Well, that's probably, she's got a DVT, a blood clot, right?
Because of that.
So it's probably, so, but the vital signs aren't consistent with it. So that's why I'm saying it's a shitty note. That's off the record. You know what I mean? Between you and me.
Yeah.
So when a patient has any surgery, and there are only 2 exceptions to this, and I'll tell you what they are. They have got to get up. Early ambulation, early ambulation, early ambulation. Because early ambulation prevents the most common complications from immobility. And the number 1 complication is a DVT. DVT means deep vein thrombosis.
Thrombosis.
A blood clot that sits and forms. Here's the thing. When blood sits, blood clots. Just remember that line. Every piece of everything in your body is always in motion. Your blood is always moving. And by the way, everything in your body is all South Philly. It's a one-way street. Okay? This is how I tell my students, right? If at any point in time, anything goes in the opposite direction, you're in trouble, right? And so when we talk about basic anatomy, your heart is a pump, and it pumps blood through your arteries to deliver oxygen to your body, your brain, your organs. When it gets to the furthest point, the tips of your tippy toes and the tips of your fingers, goes to the capillary beds, and then the deoxygenated blood goes into your veins and has to travel back up to your heart. How does the blood get back up? There's no pump anymore, right? The heart pumps it down. How does it get back up? Do you know? Muscle movement. Your veins and arteries, your blood vessels, right? Arteries carry blood away from the heart with oxygen. Veins carry blood back to the heart without oxygen. Veins have one major difference between arteries and themselves. They have valves. And so when you walk, and even when you breathe deeply, when your diaphragm goes up and down, when you breathe, when you walk, your muscles are contracting and relaxing. They are pushing the blood in the veins up, and then the valve shuts. Boom, like a trap door. Up, boom, valve shut. Up, boom. You get it?
Mm-hmm.
So that's the way blood gets back up. That's venous return. If you're not moving, you're laying in the bed, blood sits. And when blood sits, what does it do?
Clots.
It clots. So the most important thing for post-op patients is early ambulation. The second most important thing is deep breathing. Use of an incentive spirometer, or smell the roses and blow out the candles, which is deep breathing with pursed lip expiration. So, and that's to prevent another complication of post-op, which is pneumonia. We all have secretions in our lungs, but because we are up and mobile, we're able to expectorate them, and they don't sit and stagnate in the lungs. If you are lying in bed, and plus you just had anesthesia, right? And you're not really breathing deeply, probably because you're in pain. If you don't use that incentive spirometer 10 times an hour, 10 times an hour. I used to tell my patients, you're lying there. Every time a commercial comes on the TV, come on, let me see that. Let me see how high you can get that thing to go, okay? If they don't do that, the secretions that are in their lungs just sit. And when they sit, they get infected and they wind up with postoperative pneumonia. So the two biggest complications for post-op patients are DVT, post-op pneumonia. And the way to prevent them, early ambulation, frequent use of incentive spirometer, deep breathing, and pursed lip expiration. You with me so far?
Yep.
Yeah. And so the possibility here for a DVT that moved is better than the possibility of a post-op pneumonia. Here's why. Look at her temperature. Did it go up or down?
Down.
Right. So it's probably not a pneumonia, and pneumonia does not brew that quickly. You were in 8 a.m. and then you're in at 12. She didn't suddenly go from that to pneumonia, but a blood clot forms, DVT, deep vein thrombosis, forms in the lower extremities. Some of the first signs are calf pain, calf tenderness, warmth. Sometimes you'll see some erythema, some redness at the area. And if you do see that, the first thing you do is you tell the patient, don't move. Because if the patient moves, starts moving their legs, the blood clot can detach and then travel up, and it can go to one of three places. It can go to the brain and cause a stroke. It can go to the coronary arteries and cause a heart attack, an MI, or it can go to the lungs and cause a pulmonary embolism, which is probably what's going on here.
Okay.
Okay.
So when I'm filling this thing out, obviously at the times I'm going to write what the vitals were. And
Let me see that other form that you're talking about that you need to complete.
where is it? Oh, it's not on this page. Hang on.
Okay. Download that. So this way you don't have to keep opening up and start. You're going to need your own, you're going to need folders on your computer.
I do actually have a folder. Hold on.
Okay. Yeah, there you go. Atta girl. Do you know how long it takes me to explain that? This is so quick with somebody with I got to teach at a university level. I can't talk to these fucking stupid idiots anymore.
This is a Word document, but
Mm-hmm. Cassie, wait 1 second, honey. My hand is completely numb. I have to get up
Okay.
for a second. I remember I sat here. Yesterday's my double, Wednesday. And so, and I sit here from early in the morning until late at night talking. And the talking's not the worst part, but the sitting, right, is the worst part. So give me 1 second. And actually, let me grab some coffee. All right.
okay. I have to pee, so I'll be right back too.
Okay, cool. I'm going to pause the recording.
Huh?
All right. So different formats. All charting is the same because you're always giving what's the problem, what's going on with the patient, what are you doing about it, and how did that work out for you? And it's all part of what you use every single minute of every single day in nursing, which is the nursing process. And the nursing process is ADPI: assessment, diagnosis, planning, intervention or implementation, and then evaluate. And people make a big deal, oh, it's so complicated. No, it's not. When you wake up in the morning, doesn't your brain say, well, today I have to do this, 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 and this, right? You assess your situation. And then the diagnosis is, well, I've got to do this. This is the most important thing for me to do. So I want to make sure that I get this, this, and this, and then I'll do that and that later. So you devise a plan. And then you implement your plan. And at the end of the day, you go, wow, I got everything done. Or you go, damn, I got 4 or 5 things done, but I got to get that 5th thing done. And I'll put that on my to-do list tomorrow. That's the nursing process. When you go in, even before you go in, when you get report on a patient, in your brain, you're already starting the assessment process. And you can't do anything until you assess, right? Because you need to know, are they alert and oriented or are they confused? What's wrong with them, right? What kind of history do they have? In order for you to custom fit what you're going to do to that patient and their problem, right? Every question that you get, every question, I don't care what content, if it's pharm, if it's mental health, maternal newborn, pediatric, adult med surg, fundamentals, all go to the nursing process. It's simple as AdPie. See, isn't that clever? Simple as pie, simple as AdPie. Anyway, so when we talk about documentation, no matter what the format, all share the same commonalities. And those commonalities are, they must all include objective information about assessment data. In other words, you are assessing a patient, what did you find, right? And it's got to be objective. So, in other words, if you go in and you have a patient that is, say, resistant to care and they're confused, right? You would document it like that. In other words, resistant to care, attempted to put sphygmomanometer on patient's left arm. Patient tried to slap me in the face. Okay? You can't write, attempted to put sphygmomanometer on patient's arm. I believe patient is having a bad reaction from their medication. That's subjective information from you. We don't want that. We just want to know, tell me the facts. You're almost like a cop. I don't want to know how you feel. I don't care. Nobody does, only your mother, which is what I tell my students. And if I look like your mother, it's purely coincidental because I'm not her. Only in this case, I am her. Ah! Anyway, and this, I'm telling you, I say this all the time to students because they're like, then they get Miss Mary, constantly. And I'm like, you got to help yourself. I'll guide you, right? Anyway, so all nursing notes share objective data. What did you assess? Some subjective data too, because what the patient has to say is important. And that's one of the nursing ethical principles that you have to know. It's nursing, it's autonomy, the patient's autonomy. The patient must be an active participant in his or her plan of care. That's the number one nursing ethical principle. So in other words, what the patient wants, what they need, it matters. It matters when you're formulating a plan for the patient. You're trying to problem solve. If the patient likes to bathe in the afternoon, don't force them to bathe in the morning, right? Try to accommodate them within reason. If the patient says, give me a bath and ice cubes 6 times a day, well, you're not going to do that, right? And by the way, that is the nursing ethical principle of non-maleficence, do no harm. But anyway, so subjective information, objective information, and any intervention. So if you document that there's an issue, a problem, a concern, you can't just go, well, she's got pain. Cassie Lindemir or Cassandra Bohr, RN. What'd you do about it? Interventions, right? And all that's different is the format, but the content is all the same. So with pie charting is usually used. It's very short and sweet. So we're not documenting like a head to toe assessment in a pie chart. We're just documenting what's the matter, what's the problem, what did we do, how did it work out, right? SOAP notes, they used to be very popular, by the way, back in the day when I first started nursing. SOAP notes are just subjective, objective assessment plan. Again, it's the same info, right? I'm pulling one up for you to see. Give me one second. And see, so with the SOAP note, I don't know, you probably can't see that one. That is actually kind of small. Let's see if I can't find a better one. Here we go. There you go. Okay, and so it's just guiding you. The reason they even have the acronyms there is that to help dumb nurses that don't remember what they're supposed to write, right? So we're telling you, S is for subjective and O is for objective, and then your assessment, and then what are you gonna do? So subjective, what is the patient telling you? What are they telling you? What's the problem? Is it pain? Did they sleep shitty? What's going on, right? And then objective is your physical findings, vital signs. results of a lab, maybe, if that's relevant, results of a chest x-ray, some sort of diagnostic. And then when you assess the patient, what'd you find, right? So let's say that it's subjective. I slept horribly last night. Okay. Objectively, you're gonna look at me and try to figure out what the problem is, right? What is the plan when you assess me? Did you assess and find out maybe that my pain is a 9 out of 10 and that's why I couldn't sleep, right? Or I was a little hypoxic. You pulse ox me and you're like, damn, that's 94 at rest. I bet you that's dropping at night when you're lying down. Or you assessed me and my lungs have fluid in them, crackles, and maybe that's why I couldn't sleep. You see what I mean? And now the pain, what are you going to do? What are you going to do to fix it? And sometimes you can do something independently, nursing action, and sometimes you need to call the doctor. Most of the questions, hey, stop! She's fucking eating herself raw, this dog. Most questions that you get, the most aggressive answer is usually wrong. And call the doctor. Right. Once in a while, yes, call the doctor, but not often. They're looking for independent nursing action. So what can you independently do about this? You walk in the room, I'm short of breath, elevate the head of the bed. High Fowlers, it's easier for somebody to breathe if they're upright versus if they're, reclining. You get the point, right? So, pie note, soap note, source. Show you that. Can you see that screen?
Mm-hmm.
Oh, okay. Let me get. And I hate, there was one facility, Southern Ocean County Hospital, used this method, and it sucks. Source-oriented example, let me see. I mean, it's a narrative, but here, let's just find, it's probably gonna suck. Let me read this one, hold on. States, sharp throbbing pain, 7 of 10 started to, went handily down the hall, temperature, pulse, aspiration, unrelieved, change in position, meperidine, 75 milligrams. I mean, they always use pain as an example. I wonder if there's a different one. And so with source-oriented charting, basically it's like a narrative, right? The source is the patient. That's what they mean, by the way. Source-oriented means, the source is the patient. So tell me all about what's happening with this patient, what the problems are, what do they need, that kind of thing. Let's see this one. There you go. There's a good explanation, and that's actually a good explanation of it. And so everybody on the team, on the interdisciplinary team, which would be nursing, healthcare providers like doctors, surgeons, nurse practitioners, physical therapy, occupational therapy, speech and language pathology, possibly the social worker, medical social worker if they're involved, possibly the chaplain if they're involved, or the minister or the spiritual care person. And each person writes their note about the patient, about what's going on, and they're usually in narrative form. It's usually in narrative form. But with source-oriented charting, sometimes in charts you will see physicians' progress notes. They write their notes. Nursing notes. You guys write your notes, right? So it just means that it's a narrative and it's based on the patient and that particular healthcare provider. That's all. And you're still documenting the same stuff. That what you document never changes.
Right.
It never changes. And even the format, think about it. PI, problem intervention evaluation. SOAP, subjective, objective, assessment, right? And plan. What are you going to do about it? And you always have to tell me how the plan worked out anyway. So even with a SOAP note, you still have to go back in after, if you gave me pain med, my pain was a 7, go back in 20 minutes later. If it's an oral med, if it's an IV med, it works right away. That's why that other note was bad. And go back in 10 minutes later, and I say, oh, my pain's a 2. You don't have to write anything else effective. You don't have to write that. If my pain was a 7, And now 15 minutes later, it's a 2. We can all safely assume that the med worked. Right? You'll see nurses write, pain medication effective. I need you to write that.
A firewall? What does that mean? I don't know. You gotta ask Daddy. He knows the computer stuff. Sorry.
All right. So anyway, with source-oriented charting, that's all narrative. You have a lot of charting. You won't see this. I mean, I can't even give an example other than hospice. In hospice, that's what we do because everybody needs to tell me a story. The social worker has to tell me a story. The chaplain has to tell me. The nurses have to tell me a story. You know what I mean? So in hospice, yeah, but in the hospital, you will not see this type of documentation. And furthermore, most hospitals use charting by exception. In Atlantic City Medical Center, Atlantic Care, whatever, all charting by exception, okay? And charting by exception, show you what that looks like. I'm not a fan. I would always write something, always, just to CYA, cover my ass. Just, you know what I mean? Because it's so minimal. The CEO of Atlantic Care, his mother-in-law was admitted and she had a knee done. It's a long time ago, like when I first started working there, right out of nursing school. And the night shift, she bled out internally and died. And it went to court, as you can imagine. And they had just started using charting by exception. So when you look at the chart, what it looked like was at 7 p.m., the nurse came on and assessed her, and she didn't come back in and assess her till 5 a.m., which is not true. But that's what it looked like.
But she didn't write anything.
That's what it looked like. Because that's
If there's nothing to write, they're saying if there's nothing to write, then don't write anything. But you should always write something like checked on patient.
Yeah, something.
Patient was fine.
Right, right. You know, and you wouldn't write fine because fine is a subjective word.
Right, yeah, but.
Right. So let me show you. I'll see if I can find the actual one.
So basically charting by exception is only writing if there's an issue.
Correct. You're charting, you're documenting by exception. So in other words, if there's an exception to the within normal limits, in other words, what's considered normal limits for a heart rate, 60 to 100 beats a minute. If it's 60 to 100, I don't have to write anything. I'm not cool with that.
Yeah.
I'm going to tell you that their heart rate was 78 and regular, or 78 with a systolic murmur, or 78 and irregular, or you know what I mean?
So what if you do work in a hospital that uses this?
Oh, you can still chart.
And you do it the way that you want to do it. You still chart regular instead of
You don't
using
chart
this.
regular. So that's
like you just write something even though you don't have to. It's okay.
You can do that. Absolutely.
Like they're not going to be like, this isn't what we do.
No, nope. Matter of fact, when they survey nurses across the board and nurse managers, DONs and administrators,
They all prefer.
I would rather you tell me a little more objective information. Don't tell me a story with your fucking opinion in it, right? But if you were documenting objective assessment data, I love you for that. You're making my life easy, right? So, and charting by exception, I'm telling you, just, I hate it. And I always wrote a little something. I'm trying to find because it's all computer. You're not going to be writing anything.
You said objective information, right?
Objective, right.
Okay.
Yeah. I mean, you could write subjective if the patient's complaining of something. That would be an exception. So you'd write that anyway.
Right,
but I'm saying like, instead of like they're boxes that say WNL, like cardiovascular, WNL, check.
Within normal limits, yeah.
Right. And I hate that because, you know, what's normal?
Right.
Normal's a very subjective word also.
So you would go in, check the vitals. If everything's within normal limits, you would still write pulse was X,
I'd write a
BP
little
was
blip,
X.
just a little something, something. Yes, I would. A little something, something.
Normal color, whatever.
No. Color, color,
I guess it varies because people are
typical for ethnicity.
okay. Not normal, you would say. Okay, you have to be more specific.
There are words that you never use. Large, big, small, normal. right? Because what's normal?
Right.
What's big? Is something that's big to me. Patient had large bowel movement. What the fuck does that mean? Did you measure it? You know?
Batman dog.
So yeah, Batman, by the way, shits like a dog. Jesus. Oof.
You know, I'm sharing this video with my friends, right?
Well,
That's
tell
right.
them I said, hey, never will they get a nurse instructor this funny. Okay, so
You can tell who Batman is.
I am trying. So there are lots of different electronic health records. So McKesson and Cerner are two of the biggest ones that are used in hospitals. In nursing homes, point-click care is the go-to. It's the most affordable, the most comprehensive. Almost every nursing home uses point-click care. When it comes to home care, home base is the best. It's the creme de la creme. But, you know, McKesson makes a home care documentation product as well. Mysis makes one, Home Solutions makes one. So there are lots of different EMRs, electronic medical records. But with charting by exception, the two big ones are Cerner and McKesson. I'm trying to find an example of Cerner. And this is where clinical pathways and critical pathways come into play. And I'll explain what I mean, which are basically just standardized plans of care for patients based on their diagnosis.
How's Mr. Jared?
He's good. He's teleworking.
He's what working?
Teleworking.
He's working from home right now. We don't know when he's gonna be able to go in. Probably.
Somewhere. Good. Is he enjoying himself?
Maybe not right now because he's downstairs with the kids.
I'm gonna open this up and see if it has any examples. And I don't know if you knew this, but there's this site called slideshare.com, and there's a lot of free info.
Slide share, or is it this website? Slide serve.
Slide serve, I'm sorry.
Okay.
Yeah, slide serve. Give me 1 second, I'm going through. This is actually, I'm gonna download this and give this to you. Yeah, look at that. Sometimes people do nice work and they save me a lot of aggravation. Focus charting, there you go. Oh, look at this. Why reinvent the wheel? There you go. Advantages, disadvantages. Computer assisted charting. It just doesn't give you any examples. When I do PowerPoints, I try to put pictures, charts, graphs, example, you know what I mean? To make things better understood. Brevity and charting, right? And you don't need to write complete sentences too. That's the big thing. You'll be there all night. The Cardex. There hasn't been a Cardex in hospitals in 25 years. How old was this broad that wrote this? But charting has always stayed the same. You know what I mean? Yeah. Soap notes have been soap notes since before I was since Louise was a nurse. Pie notes were pie notes. Like those things never change, you know? Like the Cardex, please. It literally was a like a Rolodex. And every time a patient would get admitted, they would handwrite her name, his or her name, date of birth, diagnosis, allergies.
What?
All right, so
yeah, can you have Daddy do it?
Let me go back to this.
I'm almost done, Hale.
Haley!
She went back. She's doing school.
Is it timed, like a certain time that she does that? Or
No, she just,
her own time?
I set her schedule. I run her schedule every day. So you go on and you run the scheduler for what lessons to do that day. And they have to log 5 hours. Oh, they have to log 25 hours a week. So we do like 5 hours a day.
Right. Here, let's try this. Example of Cerner charting by exception. Let me see. That's the analytics. What's this? No. Yeah, I mean, that's actually a picture of it. So Cerner, the program, has everything in it. So the medication administration record, the MAR, which is what that's a picture of. You know, it gives you the med, and if you click on it, it'll even give you right from F.A. Davis, the drug book, all the information, what it's for, complications, nursing interventions, patient education, you know, side effects, everything. So it's actually good for that. So it's called Meducation. Clever, right?
Mm-hmm.
Yeah, genius. Billing, no, we don't care about billing. Data analytics. Oh, is this a whole YouTube video? No, it's just creating a patient list on how to do that. You know. I'll find one for you. But what charting by exception will have when you look at the screen, you pull up the patient, it'll go system by system. HEENT, which is head, eyes, ears, nose, and throat. Cardiovascular, pulmonary, integumentary, neurological, musculoskeletal, genitourinary, gastrointestinal. And in each of those body systems, there will be things with boxes next to them, check boxes, right? That'll say WNL, right? So like cardiovascular, you could just go in and check within normal limits. So in other words, let's say the patient is in because they broke a hip. And maybe everything else is, it probably wouldn't be, but let's just say everything else is within normal limits, but musculoskeletal's not, right? Because they have a fracture. So when you got to musculoskeletal, to that body system, you would not check WNL. Then it would give you more options. Sprain, strain, fracture. And then what kind of fracture? Displaced, non-displaced, comminuted, green stick. And so you could check the boxes that are applicable to what's going on with the patient. But even then, they always give you a little area where you can write something. And I would always add, even if it was just a line or two, just a little clarification, just to make sure that it was very clear, you know, that what was happening with the patient. Because if anything happens, and I learned this lesson a long time ago, when the doctor that was taking care of that CEO's mother-in-law threw the nurse, the night nurse, under the bus before you could say the word bus. She never called me. I don't know what went on. She never called me. And then they get the nurse on the stand, and everybody, we got this whole story like verbatim. And a lawyer got her on the stand, and he made her cry like a bitch. She almost lost her license. So you document with this thought in mind, that if anything ever happens, it won't come, you won't go to litigation for 10 years. You're not going to remember who the fuck Mrs. Jones was. You're not. And so you want to make sure that anything that's pertinent, anything that you did, you didn't write it, you didn't do it. And
Yeah,
so
that's actually in our notes. It
I
says,
know. That's the cardinal rule.
if it's not documented, it's not done.
That is the cardinal rule of nursing documentation. And that's why if you ask nurses and nurse managers how they feel about charting by exception, they will all go, it blows. Because nurses in a rush, and they're like, oh, this is cool. Check, 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 check. I don't know jack shit. Within normal limits, what does that even mean? Right? Especially when you're talking about things like blood pressure. My blood pressure is 100/60. That's my baseline, believe it or not, right? But I'm not symptomatic. I'm not dizzy. I feel fine, right? If somebody else had 100/60, That might be low for them, where they feel a little lightheaded when they move, right? So to say within normal limits is such a risky statement. That's why I hate charting by exception, but at least now you have a better understanding, right, of what it is.
Mm-hmm.
So charting by exception, pie note, soap note, source, which is just narrative documentation by everybody about the patient. And that's narrative. Narrative is tell me a story. Tell me a story. Tell me a nice long story. My job when I had the job at the Lighthouse, I don't know, you were little, I don't know if you remember.
The
But
rehab, yeah.
yeah, so it's when I first graduated from nursing school. So I worked Atlantic City, I worked the Lighthouse. And the Lighthouse, drug and alcohol rehab. And the one thing everybody would tell me, your notes are so good. Why? Because I love to write. And so when I would get an admission, I'd have 2 pages. You'd get their whole story, where they came from, what led them to this place, how did it happen, did they see anybody, what treatments they received before, did they work, did they not work, their family history. Like you would get everything. You get it. That was a narrative. I love writing narratives. I'll write a narrative all day long because I like to talk to my patients. Because the more you interact with your patient, the more information that you have about them, the better you can treat them, right? And it really came in handy with home care when I did the cardiac. What do you eat? What'd you eat yesterday for breakfast? Specifically, what did you eat for dinner?
BO in here. So it's like coffee and BO in here.
Wow.
What do you say?
It smells like coffee and BO in here. Because I'm drinking coffee and I came straight from the gym and just sat down at my computer. I didn't shower yet.
Yum.
Well,
Yeah.
I'll take a shower next.
Yeah, whatever, who cares?
Okay, thank you, buddy.
So where are
Did we talk about, I think the last one is problem oriented. Did we talk about that?
And it's the same thing. Now, here's what I want you to do. If it's problem oriented, you tell me, what are you writing?
You're just focusing on the issue at hand, the patient's issue, what they're here for, what they're complaining about.
Right. When you
Not
think problem,
everything, but wouldn't you still write the history, some kind of history?
just think about triage in the ER.
Okay,
You
so they come
into
in and it's, what's the
coming
issue?
into the ER, you're coming in for a specific problem. It's chest pain, it's leg pain, it's vomiting. And I am only triaging based on that problem. Now, when I
Right,
get
so
you
you're
back
gonna
in
write
there,
about, okay, you have leg pain. I looked at the patient's leg. I felt the patient's leg, you know, whatever.
you're
I
focusing.
observed this about the leg, whatever it was.
I assessed that, pedal pulse was weak and thready. The foot was cyanotic. Cap refill was 12 seconds. They have gangrene. Get back there so they can cut your leg off, Mrs. Jones. Your new
All
nickname
right,
is Stumpy.
I think I get it now, and this will probably be helpful for my my classmate too.
And
So
remember, here's the other thing too that I need to send you. I have a PowerPoint to go along with every video that I made. You know how much work that was?
I'm sure.
Yeah. I'm still not done. I'm working on endocrine. That's what I have to do this morning. I got to put my attendance in and do my endocrine system. And, when I was in school, endocrine for me was the hardest. Endocrine is complicated. Everything affects everything.
Yeah.
But I found a way to take endocrine and make it so easy. Yeah. So, but what I'll do is I will zip the file of all my PowerPoints for both farm and med surge and maternity and mental health, and I'll send them to you. Mental health, I have everything you need to know. Well, that's LPN, so you need a little bit more, but pretty much everything. That's the basis in one PowerPoint that I made. Diagnoses,
All right, cool.
how they're diagnosed, all the meds that go along with them, all the side effects of the meds, the class